When I first started looking into hospital sustainability, I assumed most of the impact came from things you could see: waste, plastic, energy use. What I didn't expect was that some of the biggest climate offenders are invisible. In this conversation, Dr. Prabhakar Devavaram, an anesthesiologist at Boston Children's Hospital, pulls back the curtain on the gases used to keep patients asleep, and how rethinking those choices have cut their climate impact by more than half without compromising patient care. I found this conversation surprisingly hopeful because it shows that even in a setting where precision and safety are everything, sustainability can actually enhance quality, not compete with it. I'm Louisa Henry, and this is Any Job Can Be a Climate Job.
So my name is Prabhakar Devavaram. I'm an anesthesiologist at the Boston Children's Hospital. So my expertise and work is in pediatric anesthesiology. You know, when you think of anesthesia, you think about taking care of the patient during the operating room procedure, providing the conditions for the procedure to be safely done. Mm-hmm. But it also kind of starts with a relationship with the patient. So, identifying the risk and generally making the families aware of the process. And after the procedure, your relationship doesn't end. You provide some form of aftercare so that the child wakes up calmly and not agitated. I think what would surprise most people is it's a happy place. We all gone to adult hospitals, and I've been to adult hospitals as a patient, and there's a little bit of dread. Children come in, the whole place is made to make them feel welcome. We have, a patient entertainment area, for example. We have child life specialists who are experts in taking care of children, addressing their needs, and making them feel comfortable in the setting. We also had clown care at Boston Children's Hospital for a longer time. We still have. They come and entertain the patients, and music therapy. So, I think it's kind of a fun place to work for me.
It sounds like a lot of fun. Definitely more fun than any hospital I've been in. And you're the director of sustainability for the anesthetic department.
Yes.
Is that a role that every department has?
No, if you ask anybody working the hospital system, what do you think about how much we use, how much we waste? The answer will be we waste a lot, or we use a lot of stuff. Right now, there is some focus on sustainability in the last 10 years, 15 years, I would say. And I would also say that there's been in the anesthesia literature regarding sustainability more kind of published data, publications coming through in the last 10 to 15 years, which kind of is our source for learning. As physicians, we are always trying to keep up to date with different things. Often there's a lot of interest, and for like-minded people like me who always thought about it, why don't we do it this way? Why do we have to throw this away after single use? That gave us an ability to look at, what is being done elsewhere, what has been successful are the things we can incorporate, and we started questioning our practice, and we've been able to create a role for me, not based on what I've achieved, but mostly based on what as a department could we create, are the things we can implement and have the same success as they've done in the areas of sustainability.
Yeah. Wow. Okay. So it sounds like sustainability has been near and dear to your heart for a while, even before you stepped into this role.
It's more of anxiety provoking, or, not having control over what is going on with climate change in particular, or say the advent of single-use plastics in particular. To understand sustainability is just not climate change, really. For me, it's more about pollution, for example. The more prevalence of some disease patterns, and it might come back to how much new diseases we are creating. For example, pollution can have an impact on cardiovascular respiratory disease. Temperature can increase mosquito population in an area not used to it, can bring a new set of diseases. And all that is not new. There have been so much studies done in that area, and it's proven. And when you read about all that, gives you a sense of, we can do sustainability, just to, not to say we are recycling better than anybody, but just to impact, the overall process, so to speak.
Yeah, I completely agree. I didn't realize that anesthesia had such an impact to the environment in general. Can you tell us a little bit about what's going on there?
The anesthetic gases are greenhouse gases, the potent greenhouse gases. Most of the focus has been on, say, the well-established gases like CO2, methane, ozone, water vapor, and all the rest of them. But less regard was given to this particular area. But if you look at anesthesia as a whole, the gases we have are, let me start. The more common one is called sevoflurane. And the second common one would be isoflurane. And
what are those used for?
Those are anesthetic drugs. They are inhaled anesthetic drugs. You
Okay.
give that medication, it keeps you asleep for the duration of the procedure.
Okay.
And you turn it off and the patient wakes up, and, they go to the recovery room.
Okay, so is this like a mask they're wearing with like tubes that go into some sort of container?
So the difference in adult anesthesia would be everybody would get an IV.
Okay.
And through the IV, you would give some medication to, induce anesthesia. The most common drug we use these days is called propofol. And then followed by that, if the patient requires a endotracheal tube or a breathing tube, you would give a muscle relaxant, which is sleep. Muscle relaxant is second part of anesthesia. For certain surgeries, you have to be still and relax so that the operation can happen. And then the third part would be giving a drug like a narcotic medication, potent ones like fentanyl, to take care of the analgesia, the pain component of it. And so those are the parts of anesthesia, 3 parts of anesthesia. So once a breathing tube goes in, the practice is to keep the anesthetic gases going through the system and keeping you asleep, and for the duration of the procedure. And there are well-defined values of what would keep somebody asleep, which is called MAC, minimum alveolar concentration. And we kind of monitor them on the machine, which tells us, how much is going in, how much is coming out, and provide the safe anesthesia. And then you supplement with adjuvant drugs. But the essential thing is sleep. So that's the inhaled anesthetic part of the equation.
Okay.
So that is in adults. In pediatrics, you have a 2-year-old. In order to decrease anxiety, to be kinder, established practice, more than 50% of the anesthetics in pediatrics would be this technique. It's called mask induction. You place a mask on the face and you give the same drug, the inhaled drug. The child breathes in and out gradually and then falls asleep. Then we place IV, and then we continue on to the next steps we talked about.
So how did you first start thinking about anesthesia and sustainability? Was it something you noticed in your daily work, or part of the research or the data that changed your perspective?
So I think for me, mostly it wasn't just anesthesia per se, which, or the literature which prompted me. Mostly, I would say my background is, I'm from South India. I trained in medicine in Madras, in Chennai, India, what's called now. And, the resources were not as, abundant as you see here in the US. So when you come here, you see the amount of stuff being single use or thrown away, and you think about, how do you kind of navigate the space? Is there any room for, how to reduce our in the items we use, or other different ways in which you can think about recycling, for example. But the thought was always there, like, can we do better? What can we do? But not knowing how.
Yeah. it can be hard to wrap your mind around where to start when you're
Yes,
when you're just
yes.
saying, okay, we have excess of everything, but what do we do?
The first knowledge-based paper in anesthesiology was what is the impact of greenhouse gases, anesthesia-related greenhouse gases, and its relevance to climate change. One of the common drug we use in pediatric anesthesia, which is used less of in adult anesthesia, is nitrous oxide.
Okay.
Nitrous oxide has a half-life, atmospheric lifetime of 114 years.
114 years. So what does that mean?
It means that its impact in the atmosphere is going to extend to way beyond what your clinical use is. So you're best to restricted use or think differently of using less of the drug or not using that at all.
How common is nitrous oxide?
So nitrous oxide has been there from the very beginning. So nitrous oxide was synthesized, I think 1772 it was synthesized. And in fact, so Boston has a history with anesthesia. Basically in Massachusetts General Hospital was the first public demonstration of anesthesia. It was done by Dr. Morton with ether, and there still exists what is called the ether dome of the original place where the first anesthesia was given.
I didn't know.
So yes, it's still there, and anyone could actually visit that place, and we have quite often. Some of my friends come from other countries, I would take them there if they're, they're interested in medicine to kind of show them that. Before ether, actually a year before that, they tried to demonstrate nitrous oxide. This is in like 1845 we are talking about. So that demonstration failed because of whatever reasons, a medical student tooth was being pulled and he felt the pain and they were like, this is not going to work. Then ether was successfully demonstrated, but nitrous oxide has always had a role in anesthesia, even from that time period. It's a very versatile drug. In adult medicine, at least, it's kind of been in disfavor. People have stopped gradually not using it at all in adult hospitals.
Are people stopping using it because of the sustainability concerns or other risks?
No. Even before that, it was in adult medicine. I would say primarily it's related to some of the large-scale studies which showed that nitrous oxide has some risk factors, and that has kind of slowly, decreased the use in adult medicine. In pediatrics, when we talk about mask induction, nitrous oxide has been the cornerstone of that. So our traditional teaching has been oxygen nitrous oxide. It's very sweet-smelling gas. It doesn't have any pungency to it. So
is this like the same kind of gas I got as a child going to the dentist?
Yes, laughing gas would be the other word for it, or happy gas, they call it. So nitrous oxide has the highest atmospheric lifetime. So the other factor which is important for inhaled anesthetic gases and their impact is their potency. So we talked about MAC, which is the minimum alveolar concentration, right? And 1 MAC of something, 50% of the patient would not move to a painful stimulation, like a surgical stimulation. So if for nitrous oxide, you are giving very high concentration, like 70% concentration to get anywhere close to that. If you're using a drug like sevoflurane, you're giving, 2.5% or something like that.
So and basically you're saying like, how much gas do I need to get to the effectiveness that I want?
Yeah. Exactly. Okay. So if you're doing that, you're going to give less of sevoflurane. So if you're giving sevoflurane, you would give, say, 2%. And if you're going to give nitrous, you're going to give 70%. Wow. So if you're going to give that high of an amount, that also has an impact on how much you release into the atmosphere. Now, the second part you need to also be aware of is that the anesthetic gases in the operating room are scavenged and vented out. The scavenging is to minimize the health impact on the people working in the operating room. And nitrous oxide is one of the earlier offending gases. So the scavenging basically takes it and puts it out into a chimney, in the highest building in the hospital, but it's unprocessed. There's no degradation. So you have a chemically intact compound which is put in the atmosphere, which goes into the atmospheric areas where the impact happens, and then eventually climate change.
And how much is that excess that's not getting metabolized by the patient?
It depends on the drug. It varies from different patients, different compounds, but it's very minimal.
Mm-hmm. Okay, so most of this is just going straight to the atmosphere. Yeah. Is it just as simple as let's stop using the worst ones and move to the better ones?
Yes.
I'd love to get into some of the changes that your team made. I understand that you were able to cut emissions by more than 50%.
In 2022, we were kind of fortunate to invite Dr. Elizabeth Hansen. Dr. Hansen and Dr. Diane Gordon, who is from Colorado, they started what is called the consortium, which is basically inviting a group of hospitals to kind of follow the similar plan, use a similar same platform. We're about 9 or 10 institutions in the first group of people. Many more, I think, are joining. About a year ago, there was a press release where 3,900 metric ton reduction, if you look at the whole impact of the entire group at that point. The number becomes big when you talk about, everybody together. There are people who think that the impact of anesthesia or healthcare-related greenhouse gases are pretty small. And if you look at the total global greenhouse gas and contribution of these gases, we are looking at 0.01 to 0.1%. But then you go into the perioperative area emissions, this becomes 50%. If you look at hospital-related healthcare emissions, we are like about 5%. If you look at total national healthcare emissions, it's about 3%. It's big numbers when you think 3% of a national healthcare emission.
Absolutely.
So the people who believe that we need to do something, would say that this is important. And we are not providing inadequate care. We have alternatives. We are not saying we are just taking away something which is so important. The alternatives in some cases are even better than, use of, desperate or nitrous oxide and things like that. At the same time, you're trying to create some change, effective change.
So you were inspired by the research, you met with these other physicians and this consortium. What did you do differently in your operating room day to day when you brought that back to the hospital, to Boston Children's?
I think what really worked for us, I would say, is apart from education, looking at the data and showing the data and showing what we are doing, how much we are doing. You can go into a little bit more granular areas, like, for example, with the EMR, with this particular platform, and even with many other platforms like the current EMR data, you can actually go and say, where is the highest use of, say, nitrous oxide? And then you can say, why is it high use there? Can things be done differently? That type of thing. Now, coming back to what worked for us, I would say is that our department has made it a mission to educate the residents, the next generation of trainees, and providing them with the tools and, being a resource, I think is going to make an impact. We constantly have, people who are left our training program who sometimes reach out with maybe a different idea, or they encounter a situation where they feel like, what were you guys doing then which helped, can you help us with that?
And do you have one of those stories with the ripple effects that comes to mind that you want to share?
A common, I wouldn't say mistake, is a common practice is, trainees drawing up more than they require just to show that, they're prepared and, and the case finishes fast. You kind of waste the medication, whatever's left. So the propofol drawn versus administered, the difference is maybe 30% in adult medicine. We think it's, much higher, like 50%. And
Wow.
that drug is probably the second most, costly medication in anesthesia-related medication. So how do you reduce that is something we were working on. And there exists this kind of a QR code where you can put the patient's weight, the dose, and the duration, and it'll say you will need this many mLs for this much time. So you're more likely to draw the right amount of drug. And
this is a QR code. Where does this live? Where do people see it?
So we put it like in different areas, like in two particular areas in the operating room where they are drawing up drugs. So and we communicate with them. Sometimes I see them not doing without it, and then I would say, okay, this is just remember how much you had drawn for this particular case. Now for the rest of the day, use the QR code, and and the amount is so different, and we are hoping to see if it makes a difference in how much we order and how much we are using and the reduction. So that's a feedback which residents are saying that they're going to. You can save that QR code as a homepage in the cell phones and continue throughout your career. So those kinds of examples are the kind of examples which make me feel good about doing this, because then if they're going to be doing that for another 20 years, it's a good practice.
Absolutely.
So
if other anesthesiologists wanted to start tomorrow, what's some simple step they could take to try to be more sustainable?
So I think the first thing is education, and looking at the resources. Many of the hospitals now have sustainability officers. We have our own sustainability officer. They are really good. They're experts in this field, and use their resources. We have quite a bit of educational support through our Society of Anesthesiology, which is called Greening the OR. So I would start with education. And
where can they find that, Greening the OR?
That's in the American Society of Anesthesiology website has it. But if you Google search Greening the OR ASA, which is our society, it'll pop up and you have all that information. So education is the first part. And almost always it's hard to just one person to do the whole thing. And, in my experience, everybody is doing it in different areas. How do you come together? In the operating room, in our hospital, the nurses have been doing tremendous work for 15, 20 years in this area, particularly to do with waste streams. So finding allies like that within your system will kind of help you to explore that area.
Great. I love that advice.
Our hospital has signed with President Biden healthcare pledge to voluntarily reduce greenhouse gas, hospital healthcare-related greenhouse gas emissions by 50% by 2030, net zero by 2050. So when you do this kind of work, the hospital is interested in you, right? So they have more awareness of your work, and we found an ally in, kind of communicating and working together.
I'm so glad to hear that the commitments to these pledges are still holding true beyond Biden's administration. That's great to hear. Prabhakar, this has been so wonderful. I really appreciate you taking the time and sharing all of your stories. I know you have a hospital full of children waiting for you, so I won't keep you any longer.
I'm always happy to talk on this particular topic, and it's been a pleasure. I've listened to some of the other podcasts, and I've been very impressed.
Oh, thank you so much. Really appreciate it. Thank you. I hope you have a wonderful day.
Thank you.
What stayed with me after this conversation is how small technical choices, like switching to a different anesthetic gas, can ripple outward into real climate impact. If this kind of story inspires you, you might be interested in Climate Swings. It's a show about people who made the leap into climate work. You can find Climate Swings wherever you get your podcasts or on YouTube at Climate Swings Pod. And I'm Louisa Henry. Thanks for tuning in. Please give it a like and a share if you enjoyed it. I'll talk to you next time.